Hello, everyone, and welcome back to the Emergency Preparedness and Response podcast series. My name is Srinath Yadlapalli, a nephrology fellow at Indiana University School of Medicine, and I'll be your host. Today's episode is part two of our discussion on water quality in dialysis. Water quality is very important for event free dialysis. In our previous episode, we discussed the foundational topics like the AMI water quality standards and some examples of chemical outbreaks. In today's episode, we will continue our discussion and cover outbreaks caused by microbial organisms and how water quality is managed during and immediately after a disaster. And most importantly, how facilities and home dialysis patients can effectively monitor their water quality when the local infrastructure is under stress. Could you provide an example of an outbreak caused by microbial organisms, such as bacteria or endotoxins, in the dialysis setting?
We've had many outbreaks related to the contamination of water, um, where water was in excess of the AMI standards at the time. Uh, these were colony counts above 200 CFU per mil or endotoxin greater than 5 EU per mil. They were mostly associated with reprocessing of dialyzers and procedural issues with reprocessing of the dialyzers and using poor quality water. So the types of organisms we've seen here is, and during these outbreaks, you had both bacteremias and patients who had clear pyrogenic reactions. And in most cases, these were due to gram-negative non-fermenters. So Pseudomonas species, Burkholderia species, Ralstonea, Stenotrophomonas, for example. And we had one outbreak in 1988 when I first came to the agency that involved non-tuberculous mycobacteria. And this is what we now realize is Mycobacterium abscessus. Back in the day, it was M. cheloni complex, which contained Mycobacterium cheloni and Mycobacterium abscessus. There was a way of distinguishing those in the lab, and we now know that even M. abscessus is a cluster, with subspecies. And we found, again, these were all associated with contaminated water and water systems. Most recently, we see again outbreaks with involving gram negatives associated with wall boxes where contaminated drain organisms and getting hands contaminated with spent dialysate. Again, in the process of manipulating the wall box before seeing a patient without hand hygiene and causing bacteremias in patients. But if we go back to the first outbreak, here was a dialysis facility that was manually reprocessing high flux dialyzers that had recently switched from using 4% formaldehyde as a disinfectant to peracetic acid. Now, patients were having bacteremia and graft infections with what we now would call Mycobacterium abscessus. And then when we observed reprocessing at this facility, they were using half strength, or almost just a little above half strength, of a solution of peracetic acid, which should have been made up to 4% to reprocess the dialyzers, and they were using 2.5% to fill these dialyzers. So these dialyzers were actually rinsed with water containing lots of Mycobacterium abscessus because there was biofilm in the tubing that they were using off their RO that contained M. abscessus growing on the inner walls of the tubing. And when so they would rinse the dialyzers first before filling them with disinfectant. And what we found when they filled with their 2.5% solution, They only filled these dialyzers until the bubble stopped. So some of these dialyzers did not contain uh, um, enough disinfectant. Um, so they were all below 1% of peracetic acid, some measuring even below 0.1% of peracetic acid, because they were only filling these dialyzers until the bubble stopped. And what we discovered in the laboratory was that when we spiked dialyzers with this mycobacteria, um, and we looked at reprocessing them the same way manually in the lab until the bubbles came out, that there was insufficient concentration of peracetic acid and there were mycobacteria survivors. When we did the same experiment using formaldehyde, we showed that these lower levels of formaldehyde were able to clear the dialyzers. In addition, formaldehyde had a more active vapor phase. And what we did here was just we used some membrane filters that were inoculated to grow, and then put them, inverted these membrane filters above a solution of 2.5% peracetic acid and the formaldehyde. And we found that the formaldehyde actually killed the organisms that were inoculated when we went to go recover those organisms off those filters. And there were, and that peracetic acid did not. And that just goes to show you that when you're manually reprocessing dialyzers, the other thing we did was if you did 3 compartment full changes where you rinsed disinfectant through the compartment volume, so you had 3 full compartment volumes in there, that you were more successful at inactivating the mycobacteria. So what we found out is that at the time, F80s, when wetted, still contain a lot of water, which was also diluting the product.
Okay.
Yep.
And now moving to environmental factors, during a natural disaster, like a flood or a hurricane, how is water quality impacted, and why does this increase the risk of infection for dialysis patients?
So let's discuss how water treatment systems and dialysis facilities can respond in a disaster. We know that it all depends on how the municipal infrastructure fails or is damaged, and whether your water treatment system will struggle to filter out uh, these contaminants which may be in the water. If the treatment plant is still pumping water there, um, the water coming to these treatment plants may contain um, high levels of microbes because of sewage and fecal contamination of water, or they contain chemicals due to agricultural runoff and/or petrochemicals because of gasoline from the cars that might be flooded, and other vehicles and oils and other things may also be in the water. So what happens when your drinking water system fails? Again, it's contaminated. If this water is being distributed uh, through the mains, it may not be safe to use, depending on the types of contaminants you have and the amount of contaminant in there. Is it easier for you to measure this? Not always. What we usually recommend to hospitals is not to use incoming water until the utility flushes the lines and brings the system back up to speed. And with hospitals, they have to have a 3-day supply of CMS requires at least a 3-day supply of water during those periods. And they may also bring in water from other sources. I remember about 30 years ago doing a flood, during the floods up in North Dakota that the hospital in Fargo, the governor brought in the military RO units, which are on the back of the truck, to pump water into the hospital building because their system had been down, was going to be down for an extended period of time. So they had these water treatment units that were brought in and then put in place. But what you really need to have is a plan in place if the water is unusable, especially if there's a do not use advisory from your supplier. Now, a do not use advisory doesn't occur that often. There have only been at least two. One was due to a tanker truck carrying. I don't remember what the chemical was, but there was a spill into the water supply, and the other one I think happened in Toledo. Again, it was more than 10 years ago, and this was where they had breakthrough of microcystins greater than the limit, drinking water limit, and they went to a do not use there. And what facilities did there is they brought in, some of the facilities brought in water in tanker trucks for them to that. And remember, in some cases, depending on the damage, you may have to consider evacuating the facility or moving to another facility that can provide services.
Thank you, Matt. The idea of municipal supply being contaminated by sewage and other contaminants like the agriculture runoff is a nightmare scenario. In these cases, boil water advisories are frequently issued, protect the
Yes.
community from waterborne infectious agents. When these advisories are in effect, is it still possible to perform dialysis treatments for our patients?
So to answer a question of what happens during a boil of water advisory, now this is usually given by a utility when there's a potential for your drinking water to be contaminated with disease-causing organisms. This may include water main breaks, detection of E. coli if they're if somehow they monitor and they have a failure in the system, a pressure drop below 20 psi's, a loss of power, and in some cases, depending on the situation, even flooding. Um, and you have to remember the utility may not test to confirm contamination. This is just, in some cases, they just go ahead and issue the alert. And if it's just the boil water advisory, yes, dialysis facilities can continue to operate and treat the water uh, because your properly functioning RO system will, again, protect the product water from that contamination. Now, what happens, though, however, if you're doing deionization alone, remember that doesn't remove or destroy bacteria or block bacteria from coming through. So if DI is your primary treatment method, you want to make sure that is followed up, that DI unit is followed up with a submicron filter or an ultrafilter endotoxin filter in place downstream. And if you use UV irradiator also to improve the quality of your water and kill organisms, again, that filter or the ultrafilter endotoxin filter should be located after the irradiator. So during the BWA or boil water advisory, it is essential to monitor the resistivity of the product water closely to detect decreases in quality. And this is not microbial quality, but you're looking at other inorganics and ions that are in the water. And you may want to, and if you see this decrease, you may want to do some weekly microbial assessments. Remember, again, DI systems the problem with DI systems in general is that they contain a lot of surface area. So if you open up a DI tank, there's a lot of little beads or resin, or the resin is a bunch of beads, and this provides a nice surface area for the organisms to grow. And I typically to refer these as, like carbon tanks, as microbial generators. So water coming off this equipment usually contains lots of microbes. So we're talking 10 to the 6 to 10 to the 8 of organisms that may come off these units, which is why it's important that the DI be properly filtered, either alone or in combination with the UV irradiator. The other thing that you may want to follow up on is your on your pretreatment side to make sure none of your pretreatment filters and carbon are not fouled.
Thank you, Matt. That tells us the importance of a downstream filter and
Mhm.
monitoring the water quality regularly during these boil water advisories. Could you discuss the increase in infections seen in patients during and after major storms, such as following Hurricane Ian in 2022?
So, following Hurricane Ian's landfall, remember this is Florida in 22. Florida Department observed significant spike in Vibrio vulnificus cases. So, this is often referred as a flesh-eating bacteria because it causes necrotizing fasciitis. It's only one of those organisms. There's and these 38, there were 38 of these cases. There were 11 deaths because it's attributed to the storm. And we have to remember that Vibrio bacteria thrive in warm, marine, and brackish waters. Again, when your coastal water, because the storm surge comes along and has an impact on your local communities, these organisms are present in the water. We have sporadic cases of Vibrio and these types of Vibrio infections every year, especially here in the Southeast and on the Gulf Coast. And we have to remember, too, that our kidney patients are often immunocompromised and have multiple comorbidities and tend to be at higher risk for severe complications and mortality from all microbial exposures. Now, they would be especially at risk here. So the general recommendation for everybody is to avoid floodwater. Floodwater, especially in warm coastal areas, may contain these Vibrio species. The same is true about swimming with open wounds. One may be at risk of these types of bacteria that cause wound and tissue infections, especially necrotizing fasciitis. Brackish water may also contain Aeromonas species. So Aeromonas hydrophila is a complex of multiple species. And these usually peak in the summer months, so you get blooms of these. They cause, and in the natural setting, they cause disease in amphibians and fish as well. And we've had instances where people in fresh and brackish water coming down with necrotizing fasciitis due to these organisms as well. And Aeromonas used to be in the family Vibrionaceae, and now it's in its with all the changes in bacteriology over the years and redefining things, it's in its own family right now.
Thank you, Matt. That example tells us why it is so important for kidney patients to be careful after floods and hurricanes and to avoid floodwaters as much as possible,
Mm-hmm.
especially for patients who are taking immunosuppressants. Now, with the increasing intensity of tropical cyclones over the last few decades, have you noticed any corresponding increase in infection risk or mortality among dialysis and kidney patients in general?
So yes, there are. We do see the risk of mortality in kidney patients. Infection may play a role. There was a 2022 study published in JASN that demonstrated that patients who require maintenance dialysis had significantly higher mortality risk in the 30 days following a hurricane. While much of this risk is driven by loss of infrastructure and mistreatments, increased infection rates are a major contributing factor. As storms become more severe and the prolonged disruption of clean water supplies and the surge in environmental pathogens, we have to remember this creates an environment for this vulnerable population. So the general recommendations are try to avoid flood water. If possible, evacuate before the storm. Have an emergency plan in place with contingency. So there's not one size fits every emergency. And facilities should work with their home patients, with their local EMS, to develop prioritized plans that include all patients and staff. Remember, if your staff can't get into your facility, it's hard to to care for your patients. So you may have to have several contingencies in place.
Uh, Thank you, Matt, for those helpful tips. Now, you mentioned briefly about home dialysis patients. For patients on home dialysis during a natural disaster like a hurricane, what should they be aware of regarding water quality? And
So,
how can
yeah.
they effectively monitor it when clinical support may be unavailable? Should they be testing water more frequently or during the disaster or immediately after the disaster?
Now, home dialysis patients, again, yes, they may want to have some emergency supplies at home, maybe for 1 to 2 weeks, maybe backup dialysate bags to use if their local water quality becomes questionable. But this also has to go with where they're living. If you're a home dialysis patient that has enough space to store 1 to 2 weeks of supplies, that might be all right to do. We also have to take into account that during and after the storm, a patient should be aware that the municipality, when bringing their systems back up online, their drinking water systems back online, may shock the system. This is also done with flushing, um, and sediment as a result of this flushing may overwhelm your home filters. So you may have to do some additional work. So considering all these things, you also may lose power. So considering all these things, patients should be trained to perform at least chlorine or at least nowadays in the old days it was chlorine and chloramine testing. Nowadays we just recommend you do total chlorine, and we use the chloramine MCL of 0.1 there. They should also be trained to how to collect water sample and dialysate samples to check for chemical and microbiological quality. If there's any doubt about the safety of the water, the safest choice is to stop using the home water treatment system and use sterile backup bags until a facility confirms the water meets AMI standards. Or do they need to do more than standard during immediately after the? So these patients should be aware the water coming to their house may be compromised or interrupted. This includes power to their home and where the equipment becomes inoperable. They should have an emergency plan in place, a 1 to 2 week supply of emergency supplies to use in the event of extended power outages or water outages. They should work with their provider and the SRD network as to where they can go to receive treatment. During and after the storm, patients should be aware, again, there might be high levels of contaminants in the water that may overwhelm their home and foul their home treatment system. Patients should be trained again to perform total chlorine testing. Again, collecting samples is important that you could send to your provider. If there's any doubt about safety, the safest choice is to stop. Do that. And find another source of information, again, is from your manufacturer.
Thank you, Matt. That was a very practical advice, especially the importance of having a sterile backup supply
Mm-hmm.
and carbon filters as a safety net when tap water is compromised. Now, moving to recovery, once the immediate threat of a disaster has passed, what are the critical steps a facility must take to ensure the water system is safe before resuming normal operations. How do we know when it is truly safe to go back to normal?
So after restoration of power and potable water supply, one must fully assess your water treatment system. Verify that the municipal water is actually meeting EPA regulated drinking water standards. If flooding has occurred, work closely with the drinking water provider since they may be using a combination of disinfection, shocking, and flushing their water supply system. Consider backwashing your carbon prior to operating your system. Perform AMI chemical analysis of incoming water to ensure the system is functioning properly. Disinfect your water treatment system thoroughly. That's both the RO and the distribution system. Conduct AMI standards analysis. Again, to confirm that you're good. And finally, perform cultures and endotoxin testing to confirm the safe and your system is performing well, and that you're validating your disinfection strategy that's in place.
Thank you, Matt. It's clear that the path back to AMI standards is a rigorous one. But in a crisis where the timeline is uncertain, patients cannot afford to miss more treatments,
Mhm.
and in a scenario where the water treatment system is non functional and physicians are pushed to a corner, what advice do you have for medical directors regarding the use of municipal water for dialysis?
While the municipal water can be used for dialysis treatments on a short term basis, patients are at higher risk of complications from bacterial contamination and chemical contaminants. Um, and technically should be referred to another facility with a functioning water treatment system um, for treatment. If your facility is using monochloramine, or if the water utility is using monochloramine, then patients may be at risk for hemolysis if total chlorine increases. And remember, there are a number of complications that can happen uh, during this time. So we can see, uh, remember there in if we go back to this, even into the 70s, when we weren't doing a lot of water treatment for dialysis, we seen hemolysis due to other chemical contaminants that might be in the water. This includes copper and zinc. Remember, your plumbing may happen to be copper at home. And we've seen aluminum leach from concrete piping from a drinking water distribution system. So these levels might be cause issues with yourself. I remember in the old days, we also had something called hard water syndrome because of the calcium and magnesium levels in your tap water. So, especially if your tap water is hard. Again, remember pyrogenic reactions due to endotoxin. Tap water may contain hundreds of times more bacterial endotoxins. I remember being told in the early 80s that if you looked at tap water coming out in New York City, that it could contain up to 500 nanograms per mil of endotoxin, and again, it's the conversion to EUs is depending on the assay that you're using as to and the control standard endotoxin. And we have to remember that all endotoxins are not created equal. E. coli is 100 times more potent than Pseudomonas, but they do cause reactions. Again, remember serum aluminum levels may show increase because of if the utility is using alum in their drinking water to cause sedimentation. You may see some aluminum coming in your drinking water. And you may see increases in chronic inflammatory response. Remember, install a temporary system comprising of carbon tanks, sediment filters, DI tanks, followed by an ultrafilter could be a choice in some instances. You may include a germicidal UV irradiator. If so, this should be installed before the ultrafilter. Consider transferring patients to centers where while repairs are being made to the system. And remember, even your facility may be impacted by flooding, where your facility is actually flooded too. So you'll also have to think about where those patients are going to go while that facility is being remediated and repaired. And thank you for having me talk to you today.
Thank you, Dr. Arduino, for sharing your expertise. This has been a very practical discussion on such a vital topic, water quality. Water quality is core to safe dialysis treatment and is challenged during a disaster. We discussed some examples of microbial outbreaks and how we can monitor water quality during and immediately after a disaster. Being knowledgeable on this topic and having these protocols in place ensures that clinical standards are maintained even at times of crisis. We have also shared practical tips for our kidney patients, nephrologists, and current or future medical directors. Being prepared allows us to provide safe and reliable care even during disasters. Thank you, everyone.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or another qualified healthcare professional. If you have any questions about any medical conditions or before or taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast by the American Society of Nephrology.